morning, everybody. My name is Claudette Medefindt from Retina South Africa, and I'm the Head of Science and Patient Services, and we're very delighted to be able to present to you this morning in this cold and rainy morning. I'm going to hand over to Gail to also welcome you.
Good morning, Dr. Florence, and good morning to all the ophthalmologists and healthcare professionals from the East London area. Thank you for joining us. And it gives me really great pleasure that after 30 years of being part of the life of the ophthalmologists in the East London area and the optometrists, that we are still able to meet with you, and that they've always been such dedicated professionals who have supported Retina South Africa in that area. And I can remember the very first contact 30 years ago with Dr. Alexander, who I do believe is retired now. So we're still connecting with you and sharing our information with you. And from our side, we'd like to thank you for all the referrals that have come from your hospitals and practices in that area. So thank you very much, and welcome to you. I'm hoping that we will grow together as Claudette shares so much new information with us. And to have on this webinar my colleagues, Claudette and Karen, who are both really experts and world-renowned, I would say, Claudette, in your fields. And it's a privilege to have you share your information with us this morning. Thank you, Claudette.
Thank you very much. Dr. Florence, would you like to say a few words?
Good morning, everybody. I'm Florence Nchianiwadu. I'm working at Cecilia Makiwane Hospital as well. I think it would be apt to introduce my other colleagues that are here with me today. We are coming to you from the Eye Centre in East London, which is a private institution headed by Doctors Andrew Balaita and Dr. Stephen Cook, who are in here with us as well. They also have two other ophthalmologists here, Dr. Erica Kleinhans and Dr. Merrick Ryans. From the state side, I'm here along with a few of my colleagues as well. In his absence, our head of department, Dr. Samuel Berwa, unfortunately couldn't be with us this morning because he had to be in Cape Town for I do have with me our registrar, our only registrar currently, Dr. Christina Sophocleus. In their absence, we have Dr. Rachel Galibolo, who was unfortunately due to student exam today and is unable to join us. Dr. Oyama Njela should be joining remotely. She's unfortunately sick in bed. We also have other consultants who are doctors who are based in the hospital we have come in contact with. Dr. Alan Thompson and Dr. Ashari. Today we have a doctor joining us from the Family Medicine Department at Cecilia Makiwane. He is involved in some diabetic screening that side. So we are actually quite happy to join us today. And that is Dr. Liz. And then we have an intern, so going forward, someone who might also maybe come to be of help and use to us, and that is Dr. Sarah. So that's those of us who are here currently.
Thank you.
Right across from you. Sorry. We have Nick Gosha, and he is our optometrist and medical manager here at the Eye Centre as well.
Thank you very much. And we'd like to thank Dr. Balata and Dr. Cook for your for hosting this. It's very kind. I've actually been to that beautiful practice and presented there myself, and I know it's a very welcoming place, especially on a cold morning. I'd also like to introduce you to my colleague, Karen Denton. Karen, would you like to introduce yourself?
I'm Karen, and there's not much to say. I head up education and advocacy for Retina South Africa, and it's a pleasure to meet you all.
And Karen is very modest because she's also a world-renowned speaker on her speciality, which is diabetic retinopathy and AMD. Well, a lot of you know us. You know that we were established in 1980, and we're only patient support and advocacy NPO, providing free services for retinal patients throughout the country. Next slide. That's our team up here, our support team. Karen and I with our 2 social workers, and in Port Elizabeth, we've got, of course, Gail and the social worker, Yanela Hofu. And between them, I think they probably speak about 8 or 10 languages, and we do cover remotely. And thank goodness, one of the good things that came out of COVID is Zoom. And so we can cover the whole country very easily now without having to bundu bash all over the place. We can connect with people. And we provide services to all people with retinal conditions. And you all know about that we cover the genetic ones. The most common ones, of course, that you're going to see are retinitis pigmentosa, Stargardt's, Cohen-Rod, Usher syndrome, and then the rare conditions which you may come across probably a couple of times in your life as a practicing ophthalmologist, but we cover all of them. And then, of course, age-related macular degeneration, and now also diabetic retinopathy. So what do? We offer a comprehensive service to patients. We need to identify the patients, first of all, and that's really where you come in, because without our ophthalmologist referring, we can't identify the patients. We give the patients disease-specific information, education, counseling, support, and we intervene where we can. We also offer peer support and mentoring, particularly to our young patients, because we have young people who are really making a success of their lives, and they can help them also to train them with all the amazing apps and assistive devices that are now available, and most of them free. And people honestly say, wow, when we show them how to use a smartphone well, or how to use the free services on their support services on their computer, like Narrator, etc. So we can offer that advice. We have a patient registry, which is POPIA compliant, and where applicable, we facilitate genetic testing. We refer people to low vision optoms, occupational therapists, assistive device companies, orientation and mobility services, skills of daily living, schools, to audiobooks. The list is literally endless. And then, of course, we collaborate with you, our South African clinicians and our local researchers, and also internationally. And we do a lot of advocacy, especially in clinical trials and accessible treatments. And Karen will tell you more about that later on. So next slide, please. Why are referrals essential? Well, if you refer somebody to an optometrist, that service is essential, but it's only one part of the services that can help them. A multidisciplinary approach uses skills and experience of individuals from different disciplines, with each discipline approaching the patient from their own perspective. And once you put all those pieces together, what you're going to get is a completely rehabilitated patient. So let's look at the pathway the patient has. First of all, identification. That's where you come in. And then we start looking at intervention. So we need the patient to join Retina South Africa. Karen will talk to you about easy new ways of joining Retina South Africa or getting your patients referred. Then we do a needs assessment by a social worker in their home language. And that's very important because Karen, for example, does a very good talk, titled You Don't Know What You Don't Know. And that is so important in low vision. People have no concept of what services and what means they can use to improve their quality of life. We also do psychosocial support, referring them on to psychologists if we need to. We do condition-specific information, and that's very important that the patient understands. We do intervention wherever necessary. We look at coping skills and devices, and then we refer. Special needs service providers, genetic counseling, facilitating of genetic testing. And then from our patient registry, we will look at assessing people for inclusion in clinical trials. And that patient registry is a gold mine. We've got phenotype and genotype diagnosis and information and family history. And as I said, it's POPIA compliant, it's password protected, and we ask for biometric, for authorization from patients to exchange any biometric information. So for those of you who know, and I know for the ophthalmologists, they're yawning now, ho-hum, peripheral vision loss is generally initially rod loss, and that includes retinitis pigmentosa, Usher 1, 2, and of course now we've got 3 as well, which is retinitis pigmentosa plus hearing loss, Leber's congenital amaurosis, LCA, which of course is the first condition where a treatment is available. Unfortunately, it's out of range financially from South African patients, but we are working with Novartis, who bought the rights outside of America, and they are looking at bringing it to some LCA patients, which is good news. Choroideremia, of course, is important because it really is progressing very well in clinical trials. And then Refson's disease is important, and I'll get back to that a bit later. What are the symptoms? Poor contrast vision, night vision, and that includes subdued lighting problems, delayed light to dark adaptation, and actually that bugs young people the most at school, where they come in from a brightly lit playground to a slightly darker classroom. My eyes take about 10 minutes to adjust. So you can't, if you walk into the classroom, you fall over the cases, and then the teacher asks you to read, and you can't even read. You don't even know if you're holding the book the right way up. And then, of course, as you see in your practices, eventually you start to get field loss. And something very interesting, the rods produce a survival factor for the cones. It's called cone viability factor. But when you reach a certain threshold of rod loss, is insufficient of that viability factor being produced, and then people start developing central vision loss. And very often they'll go back to the ophthalmologist and they'll look at your VA and say, oh no, you don't have RP, you actually now have cone rod dystrophy. But in fact, it is this loss of this factor. And the good news is it's in clinical trial. They've actually identified the factor and they've synthesized it. So it is now in clinical trials to actually supplement that cone viability factor. Then we go, of course, to central vision loss, cone loss initially, and you're all familiar with Stargardt's. And we know that fundus flavium maculatus is a slightly different clinical appearance to Stargardt's. And somebody long ago said, oh, it must be a different disease. But actually, genetically and functionally, it is exactly the same disease. Then, of course, we get the cone and the cone rod dystrophies. Achromatopsia is very interesting, and we'll come back to that. And age-related macular degeneration is also a central vision loss. The symptoms are poor visual acuity, reading, writing, face recognition. But you will have known by working with people in the clinic that color vision isn't always affected. And that's what's quite amazing, that those few cone rods that are surviving do provide some color vision. And we say that it's juvenile onset, but you know, it's very variable. Sometimes when you get a patient presenting at the age of 40, and you look at it and it doesn't look like age-related macular degeneration, and actually looks like Stargardt's, it may well be, because we do know cases where Stargardt's onset is very late in life, and that is because of the different mutations involved. Some are more damaging, present earlier with more severe vision loss, and others, different mutations, are less lethal and they present much later and have a much slower onset. Why is a genetic diagnosis critical? Well, you know, when a person comes in and presents, unless you do a scan of tests like OCT, etc., it's very difficult to diagnose in the early stages. You also, the patients always want to know about prognosis. And unless you actually know specifically not only which gene, but as I said in Stargardt's, which mutations are involved, you can't give them any kind of prognosis. They also want to know about risks to offspring and family members. We need to identify the disease risks. For example, if you have Stargardt's or cone rod dystrophy that's caused by mutations in the ABCA4 gene, the patient must not take any vitamins containing vitamin A or beta-carotene. They can handle a certain amount of beta-carotene in their diet, because we all know that there are other cells in the body that require vitamin A. So they can handle a certain amount of yellow vegetables, but we wouldn't certainly not recommend them to drink carrot juice every day. And then, of course, the big thing with Refson's disease is the phytanic acid buildup, which can be fatal. So if you have a patient coming in that presents like retinitis pigmentosa, ask them about their sense of smell. if they have loss of sense of smell, ask them to take off their shoes and socks and look at their toes, because people with Refson's disease have sometimes an extra digit or malformed toes. And if you exclude dairy products out of a patient with Refson's disease, you can actually literally save their life and stop the genetic degeneration in its tracks. So that's a very important one to know. We also know that people with Stargardt disease and most cone and cone rod dystrophies should not be exposed to high ultraviolet light. So they need to be encouraged as children to wear hats and to wear UV protection sunglasses, because we know in animal models that it does accelerate the degeneration. People with who've got a genetic diagnosis can also have informed reproductive choices, and Gail will know, she's had a couple of people in her area that actually have followed the route of having in vitro fertilization and spousal testing, and then you can test the embryo at the 8-cell stage and check which embryos don't have 3 copies of the mutation or 2 copies of the mutation in the ABCA4 gene, and those embryos can be implanted for a successful pregnancy without the risk of the child being affected. And then, of course, the important thing is clinical trials at this stage are very much gene specific, and without a genetic diagnosis, people can't be eligible for clinical trials. And upcoming treatments, many of them, and for example, the Luxturna one that's available now for LCA is not only gene specific, it's actually mutation specific. Inherited retinal conditions are inherited in 3 different ways. Recessive, where there's carrier parents who are not affected. Dominant, where one patient is affected and the carrier, and that's in my case, I've got dominant, my father had it, and my 2 sons have it. And then X-linked, where an unaffected mother is a carrier. But sometimes, and particularly in the Eastern Cape, we have an X-linked that's dominant, a pseudo-dominant, where this whole story of was it X-linked or dominant is quite difficult. But it's usually mild symptoms in the mother. And of course, for those of you who haven't seen, of course, you've got the recessive carrier and mother and father, and there's a 1 in 4 chance or 25% chance that the child will inherit the gene without the mutation from both parents, a 2 in 4 chance, 50% chance that the child will inherit the mutation from either mother or father, or a 1 in 4 or 25% chance that the child will inherit the gene carrying a mutation from both parents. And you have that possibility on each pregnancy. So it doesn't mean to say if you have 4 children that they will follow that pattern. Then we have autosomal dominant inheritance, which is, as I said, from one parent, mother or this is father, this is not gender specific. You have a 2 out of 4 chance that the child will inherit a good copy of the gene from the affected parent, and a 2 out of 4 chance that the child will inherit an affected gene, a mutated gene from the carrier parent. So 50% chance. And unfortunately, in my case, I had both my sons inherited my dominant gene. Next slide, please. Then, of course, we've got the classic X-linked recessive, where the mother carries a mutation on one of her X chromosomes, but she also has a good copy of an X chromosome carrying a gene that is not mutated. There's a 1 in 2 chance that her daughters will either inherit either the good X from the mother or the bad X, and again become a carrier. And then, of course, when it comes to sons, if the mother's a carrier, there's a 50% chance that the child will inherit the X gene with the mutation from her. And of course, he can't inherit an X from his father because he's a boy, so he will inherit a good X from the mother. So again, a 50% chance. And before there was genetic testing and we had identified a lot of the X-linked RP genes, when the mothers did tests on the fetus, if it was a male carrier mother, would actually abort the male fetus. And of course, that's no longer necessary because we now can test her and we can test the fetus. So some of that 50% of the time, that fetus need not have been aborted. So what are we looking at for therapy? What are the therapy pathways? Well, there's gene therapy to actually deliver a functioning copy of the gene to the cell, or to deliver DNA that causes another protein to be produced. Stem cells, the holy grail, It's still not there yet. And if your patients ask you about going to China or Germany or America for stem cell treatment for any eye condition, it's still 5 years, at least 5 years away. So we know they're growing quite successfully retinal pigment epithelium replacement for Stargardt's or age-related macular degeneration. They're trying to grow photoreceptors, and on scaffolding, it's looking quite good. Progenitor cells that will become photoreceptors are progressing, but not there yet. And then, of course, we've got the gene editing. Now, before COVID, nobody had ever heard of microRNA editing. We all know now that all the work done in mRNA editing by cancer and retinal people actually served the COVID anti-vaccine fraternity well, because they knew how messenger RNA editing worked and they were able to adopt that and use it for the vaccine. Of course, CRISPR-Cas9, I'm sure you've heard of, which is a mechanism that's always been used by bacteria to knock out viruses and is now in clinical trial. Optobionics are really exciting. Although the photoreceptors are degenerating, the neural layer, and particularly the ganglion cells, is what they're looking at, can actually be converted now to have photosensitivity. And then a picture, a message can be taken via the optic nerve to the brain, and that's called photoswitching. And it's very exciting, and the clinical trials are looking very good. We know that they don't need to reconnect with the photoreceptors because you take the photoreceptors out of the equation completely. So that is looking very promising. And then, of course, there's a whole host of pharmaceuticals like visual recycle disruptors, supplements, proteinomics, and we know in AMD, Corin will go into the anti-VEGF story. Towards clinical trials, how do we bring our patients from out here in the wilderness to the yellow box? So, we know that optometrists are very important because they are usually the first eye care professional that a patient will see. And then, of course, they suspect something, they can't diagnose it exactly, and they'll refer to an ophthalmologist. And the ophthalmologist is absolutely crucial because when you have a diagnosis, we need to refer to Retina South Africa. Where applicable, we will then make sure that they get genetic counseling and genetic testing. And also we will look at needs assessment and make sure that they get the specialized services and skills that they need. And then hopefully we can get them into a clinical trial. And eventually, of course, here we want to move everybody into that yellow basket of treatments. And it takes a team. It takes all of the people that we mentioned. So let's look at the clinical trial that we are involved with at the moment here in South Africa. It's an Acusella trial for Stargardt's. The drug is immuexostat, which is a vision disrupting drug. It's in phase 2/3. It's double masked, so of course there's a placebo, and it's a daily tablet for 2 years. And we're expecting those results out at the end of the year. When we were asked to look at our database, we had 320 members with a clinical diagnosis of Stargardt's, which was the first criteria. When we looked at those, we examined those, 250 had a genetic diagnosis of 2 mutations of ABCA4, which was the second criteria. Of those, there was a BCA cutoff point, and 90 people complied. That was the third criteria. And then they had to have an OCT, special OCT test, to look at the size of the lipofuscin in the retinal pigment epithelium, because that was what was being measured. That was the outcomes measure for the clinical trial, was to look to see with the disrupted drug, did those lesions grow? Did they stay the same, or did they reduce? And we're hoping that if this trial is successful next year, that will be available as a treatment. But of the 30 sites that around the world that participates, I must tell you that the retina team headed up by Dr. Liesel van der Merwe at the eye clinic in Pretoria was the top recruiter, and we were very thrilled with that. So let's hope for next year for treatment for Stargardt's. So that's me done, and I can take a sip of water. And now Corin is in the hot seat. We'll take questions at the end if it's all right with you guys.
Okay, I'm very delighted to be here chatting to you today. So thank you to everyone for this invitation. I'm going to talk very quickly because I know that this is going to be revision for all of you. And I'm going to go really, really quickly. I'm only going to say 2.5 words about macular degeneration because we know quite a lot about it. We know that there is a huge number worldwide. And although it used to be in people over the age of 70, then 60, then 50, they're now picking up early warning signs of drusen in patients aged in their late 30s or early 40s. And it is still the leading cause of blindness in certain populations around the world. We therefore say that everyone over the age of 40 should have a regular eye test just to make sure. So we encourage all our people to visit you very regularly. Now, the interesting thing that has come out in the last few years is that historically, nobody has really looked at the Black population because it was believed that there is no macular degeneration in the Black population. But I think it was about 2 years ago now, Claudette, we were in a meeting with some doctors from Kenya, Uganda, Nigeria, and they were saying that now that they're looking for it, they're actually finding macular degeneration. And based on this, I've had a look and there isn't much research, but everything seems to be very consistent. Wherever it is found, the number of whites is double that of blacks, but it does not mean that there are no Black people with macular degeneration. They're there. And if you look at a country like ours, where the number of white people is so small, the ultimate number of people with macular degeneration, the gross numbers in our local population is going to be really, really, really high. And it's something we need to start looking at because very few people in this country are even looking for it because the belief has always been there that there is no such thing. We also know that the drusen, the hallmark of AMD, were described more than 150 years ago. But in spite of that, very, very few people actually look for it. And we know that in our population, people don't go to have their fundi looked at. And I'm going to touch on that problem again in just a moment, because you guys should be the first person that so many of our patients should be seeing. Because it just takes a simple eye examination to diagnose so many other conditions. And I'm just going to say one word about the anti-VEGF injections. Just as a reminder, there are 3 available that are licensed, plus one that is off-label. Now, if you're giving the one that is off-label and it works, fantastic. We are in full support of that because it is very, very cost-effective in comparison with the others. However, if it's not working, there is no point in pursuing that. And if after 3 months, you're not seeing a stabilization of the condition, the patient does need to change to one of the registered formulae. I'm now going to talk a little bit about the eye, COVID, and diabetes and what the links are, because this is of huge implications to every single person sitting here today. We all know that there are different types of diabetes and that broadly we talk about type 1 and 2. Type 1 meaning that you need insulin, type 2 you might require insulin, maybe not. But we do know that each person is individual, and it is often said that there are as many types of diabetes as there are people with diabetes. The diagnosis of type 1 is very straightforward, usually because it has a very abrupt onset. By and large, many of these are younger people with, as I said, a very sudden onset, but very, very severe symptoms with extreme thirst, extreme urination. They start wetting the bed at night, even some adults do. Extreme hunger, weight loss, and then because the glucose is not reaching the cells, extreme lethargy as well. And in contrast to type 2, which you can have a look at the little picture on the left. Usually the person is of mature age, but we now have young children, school kids with classical type 2 diabetes. So we no longer classify it as a mature age onset diabetes. The onset is usually a lot more gradual than type 1, and the symptoms are a lot more subtle, especially in the beginning, with a little bit more thirst, a little bit more urination, get a little bit more hungry. But very, very important is that central weight gain. So if you see somebody with a big middle, you should really drag them in and look at their eyes. And they also have recurrent infections. If we look at epidemiology worldwide, the commonest causes of new blindness in developed countries, AMD, and in developing countries, diabetic retinopathy. So that means that in South Africa, where we are both, we have a double whammy. We have both of these. And we also know that 1 in 3 people with diabetes have diabetic retinopathy, often at diagnosis. And the blindness is 20 times higher in people with diabetes. And one of the major problems is that blood vessels with diabetes are destroyed. And at the same time, the little blood vessels feeding the nerves are blocked, destroyed, so the nerve cannot be nourished. But the nerve itself, glucose flows freely into the nerve, converts into a product called sorbitol, and it causes death of that nerve. So the poor nerves are really at risk. And we know that all over the body, this can happen. And if it's in the little blood vessels to the eye, especially to the central area, we have a problem. But in diabetes, the problem starts peripherally. And you can have these little aneurysms, hemorrhages, little exudates, and the patient will be totally unaware of this, completely unaware, until the damage is so severe that it is impacting their vision, and they then finally do something about it. And this is diagnosable 10, 15, 20 years before the patient is even aware sometimes that they have diabetes at all. And that is a shame, because in our country, everybody who has a little bit of a book, which is most of us, you'll see just now, needs to have their eyes checked every single year to pick up this problem, because the blood vessels are blocking, and sooner or later a disaster is going to happen. Diabetes is such a big problem that it has been picked up by the world media, even the non-professional media, Time magazine, News magazine, places, things like that. And even the World Economic Forum, a non-medical body, stated the year before last that there is a silent epidemic 3 times more deadly than COVID, and that is diabetes. So we need to have a look at this. When I started in the diabetes world, which was 1985, there were approximately 25 million people worldwide with diabetes. And we were very scared that by the time the millennium came around, that we would have doubled that number. Well, by the time the millennium came, we'd gone from 25 to 250 million people with diabetes. And today we are looking sadly at encroaching onto 600 million, with more than 570 million people worldwide with diabetes. And if you look at the number of them who have diabetic retinopathy, it is enormous, and the numbers are increasing as we sit here. We have, guys, we have a catastrophe. This is a health catastrophe and a catastrophe for the vision of our people. And this is the reason. We are eating rubbish, we're eating incorrectly, we're eating foods that we should not be having. And that is the main reason. If we look at diabetes and obesity in, for example, the States, and I'm only using the States here because they keep such amazing stats, you'll find that just 40 years ago, the number of people with obesity and diabetes was less than 5%. Today, it's like 30 to 40%. So that is unsustainable. That is a health product that is problem that is unsustainable. And it is also affecting children. And we know that even today, we have children up to 40% in certain states who are overweight and obese. In fact, 1 in 3 children in the States is overweight or obese, and they will grow up to be overweight or obese adults, and their eyes are at risk. Because as I said, if they have that central obesity, they're in trouble. In fact, when Michelangelo's David went on a recent visit to the United States, he just spent 3 weeks there, that's all, and he came back to Florence looking like that. So we cannot sustain this. This is an absolute problem. And people often say, oh, but we're in South Africa, we're not affected. So I then looked at the official figures for South Africa, and the published figures for 2021 are really alarming because, guys, 1/3 of you are overweight or obese, and ladies, to our shame, 68% of us, 2/3 of us are overweight or obese. And this is mostly central obesity, and that is a problem. Now, why am I talking so much about obesity when we're actually talking about diabetes? And the reason is because central obesity and type 2 diabetes are one and the same thing. You cannot have central obesity without diabetes developing. You might or might not be aware of it. And you cannot have type 2 diabetes without some of that central obesity. It's very, very rare. If we look at the number of people who officially have diabetes in South Africa, it is averaged out at 12.8%, which I think is quite conservative. And if we take that into real numbers, if we look at our adult population, these are people over the age of 18. There are 49 million people over the age of 18 currently in South Africa. And if 12.8% of them have diabetes, we have between 4.5 and over 6 million people with diabetes in our country today. 4.5 million and we know that fewer than 1 million of them are being treated adequately, or if at all. Fewer than 1 million are being treated. We really need to step in. And so many of these don't even know that they have a problem. Together with this, obviously, I've mentioned the diabetic retinopathy and diabetic macular edema. The numbers are staggering and increasing every single day. And very sadly, even after diagnosis, very few doctors look into the eyes. We had in our office just the other day a very prominent businessman that came for a meeting with Claudette and myself. And when we were chatting and we spoke about this figure, he said, but I've had diabetes for longer than 20 years and no one's ever looked at my eyes. Are they supposed to? And he is seeing a so-called diabetes specialist in Johannesburg, and he has never, ever had his eyes looked at. Well, he left us and went straight off to go and get that sorted out. Unfortunately, if you have a look at the number of people with diabetic retinopathy, in Africa, we lead the way with just on 36% of our patients who have diabetic retinopathy. But in my figures, I am going to stick to the 20% that I mentioned earlier. But you can easily double everything that I'm going to say. So if 20% of the people worldwide have retinopathy already at diagnosis, but that research showed that it's actually double that, in South Africa, this means that we're probably sitting with about 1 million people today with diabetic retinopathy. We have probably maybe 20 people with diabetic retinopathy on our registry. These are all people that we should be, could be counseling, helping, sending to you for help, advice to sort out the looming disaster that is coming. So, who should we be looking at? I've mentioned time and again that it's people who are shaped like an apple, not like a pear. If you have a narrowish waist, and I will show you now that all you need to measure that is a piece of string or ribbon or anything like that, and you simply tie it around your waist. To find your waist, you just bend, and where you bend, that's where your waist is. People often don't know where to measure their waist. It's anywhere from the boob line down to the knees. And the hips are exactly the same. It's where your leg bends to join onto your body. And if you measure your waist and your hips, if your waist is smaller than your hips, fantastic, you are quite fine. If your hips are larger than your waist or even the same size, you either have a problem or an impending problem. And I would say that when you guys see anybody walking past your consulting areas who has a bit of a book, you need to really drag them in and look at their eyes. You'll be doing them and the country a massive favor, because we cannot sustain the number of people who are going to go blind from this disaster. And the main reason is because when there's a little bit of extra glucose in the body, and I will show you that in a moment, it goes to the liver, and the liver converts it into triglyceride, which is, as you know, a fat. And it either dumps that along the blood vessels or into the closest area, which is into the intra-abdominal area. So you start getting this intra-abdominal accumulation of fat. So intra-abdominal accumulation of fat simply means you've been eating the wrong things and the fat has been accumulating in that area. And sadly, when we see people with a large book, we very often call this insulin resistance syndrome. And I cannot tell you how many calls we get from people saying, oh, the doctor said I've only got pre-diabetes, I don't have to worry about it. And I just want to remind you a few things about pre-diabetes, because the first thing that the person's going to know about this is when they have cardiac infarction, when they have a heart attack, when they drop, or they have a stroke, or some disaster happens in their lives. In other words, pre-diabetes is in fact a ticking time bomb. And sooner or later, the blood vessels should be nice and open and patent like this, are going to start blocking until eventually they occlude completely, and the patient does have that myocardial infarct, stroke, or lose their limbs. If it's a vessel to the eye, the blood supply to the retina is disrupted, and we start getting all the diabetic retinal problems as well. Now, I'm just going to touch very briefly on COVID and diabetes. I've mentioned already that at the World Economic Forum, they said that diabetes is 3 times as deadly as COVID. And we know that COVID is pretty deadly as well. And diabetes killed 4.2 million people in 2019. So if we add the 2 pandemics together, we then end up with an obesity and diabetes pandemic plus a COVID pandemic. And the link between these two is actually quite scary. So if we look at the risk factors, we know, and we've known right from the start, that if you have diabetes or obesity, your mortality and morbidity risk for COVID is extremely high. And the studies that came out within a year, in fact, of COVID first being found, actually confirmed this. So the anecdotal reports that we're receiving were confirmed really quickly. We also know that nearly half of Americans gained weight in the pandemic's first year. And we don't have research for South Africa that I'm aware of or that I've been able to find. But anecdotally, when I speak to people, people say, yes, I gained weight. And I know that I personally was one of these. I would sit at my computer working all day long because we work from the computer. And every time I took a break, I thought, okay, what should I do now? I can't go out. I know I'll have something to eat. So what do? We pop along to the kitchen and have something to eat. So we were a little bit naughty about that, all of us. People were more likely to gain weight if they were a bit overweight before the pandemic started, also if they were depressed or anxious, and if they had children at home. The Food Business News did an international study where they found that 8 out of 10 consumers changed their eating habits during COVID, and this eating pattern has been sustained, sadly enough, and it does not change for the better. People started to choose inappropriate food choices, more free home snacking, and they chose cheaper foods. We also know that there was a lot less exercise because people weren't venturing from their homes. They were too afraid. And they working from home just meant that they didn't have to walk up the stairs to their office, etc., etc. And even children were extremely adversely affected during this time. And they found that during this time, most children had at least one extra meal during the day, full meal. So if we have a quick look at what makes the obese host so vulnerable, which means then obesity and diabetes, why are you so vulnerable to COVID? And it all is because of the ACE2 receptor, which is expressed when you are obese. And the ACE2 receptor is an open door for the SARS-CoV virus. It gets a direct access through the ACE2 portal into the body and then spreads. When once it gets in, it is there. And then we have a total inflammatory response. And we know that people with obesity and with diabetes already have an impaired immunity. So they cannot even do anything about this. So they are at major risk. So that is the one side of the story. The other side of the story is we know that just like the Coxsackie virus possibly still does, also the COVID virus attacks the beta cell directly and wipes it out completely. And when the beta cell is wiped out, the person, they cannot manufacture insulin and they end up with type 1 diabetes. So then not only in summary do we have a worsening of diabetes symptoms and outcomes, there are people with diabetes or obesity are at increased risk for severe COVID and at risk for newly diagnosed diabetes, because as we said, COVID totally destroys the cells in the pancreas and they end up with type 1 diabetes. So this is a major problem. So the link between COVID and new diabetes has been completely established worldwide. And people are developing both type 1 and type 2. There is a bidirectional relationship. The one affects the other. COVID causes diabetes and diabetes causes COVID. And we know that 14.4% of people in the first year who were hospitalized with COVID were newly diagnosed then with diabetes. And not only that, in the follow-up year after that, it was found that if you had even a mild infection of COVID, just a mild COVID infection, your risk of diabetes was approximately 40% within the next year. And that is now still being tracked to see if that is being carried on, because as the headline said, COVID increases the diabetic risk 40% a year after even a mild infection. So guys, we have double trouble. We have a country who is at risk for obesity. We have a country who do not even know that they have a problem looming. They do not even know that they can go to an ophthalmologist and have their retina looked at to see if there is looming disaster. You can diagnose diabetes 10, 20 years before they even know that they have it, before they have that visual disruption, or they have a myocardial infarct, stroke, before they lose a limb, all of those things that at the moment, very sadly, are called pre-diabetes. So we need to intervene urgently. We need to get out there, get the people moving, get them into some program to prevent this disaster, because even economically, South Africa cannot support this kind of situation that is looming in our future. The retinopathy, myocardial infarct, strokes, the problems that are coming our way are unsustainable. And we should start intervening today at that very first sign. Now, there's certain things we can't do anything about, like race, ethnicity, history, age, but we can do something about physical activity, blood pressure, cholesterol levels, and fat. And we need to encourage our patients. They don't have to only eat green leafy vegetables and lots of highly colored food. But they need to include those into their diets. I know you're not going to change people's habits overnight. So if they are eating incorrect things, if they do want a burger, encourage them to have a really nice big salad with it, with lots of green leafy stuff with it. And encourage people to exercise. They don't have to join a gym. We're not saying go and run marathons. We're not saying any of those things. We're just saying keep moving. And we know that studies have been done, and even people who sit fidgeting a lot actually burn quite a significant number of calories as well. But if people can just do armchair exercises or do anything to keep that blood flowing, that is the important thing, because insulin also cannot function without movement. Those cells, the muscle cells, will send a message saying, give me glucose, and the only way the glucose can get into the muscle is with that insulin. So exercise is going to predetermine how well that insulin is used in the body. So keep moving. Tell your patients to keep moving. We also make sure that people's glucose levels are more or less looked after. And I know that at the moment, one of the worst things that we come across is glucose variability, where sugars swing up and down and up and down. And that has been shown to be the most damaging factor in blood vessels and in interfering with the well-being of our bodies and interfering with various substances that can protect us, like antioxidants. We need to control, as I said, lipid levels and blood pressure as well. There are all kinds of different pharmacological treatments for type 2, and they are simply diagnosed according to the way that the person presents, because, as I said earlier, there are probably as many types of diabetes as there are people with diabetes. So they all probably need something completely different. And insulin is an absolute must for people with type 1. And people with type 2 may or may not need insulin. They may need it for one dose, for 1 year, for 1 month. They'll need it for as long as they need it. And I mentioned the anti-VEGF injections, just to remind you again that exactly as we mentioned for AMD, there are 3 that are licensed and 1 that is off-label, and just that if one isn't working, the others. And we also do give our patients a guide on when to see the doctor, but it is entirely the ophthalmologist's decision. If it is mild, moderate, severe diabetic retinopathy or macular edema, and we then advise them to follow your advice, but to stick to these appointments very, very, very astutely, because it is so important that they are followed up all the time. I could have summarized this entire talk in this slide, just saying that everybody needs regular checkups, and we need screening for everyone over the age of 40 and everyone who has a book. And as Claudette mentioned earlier, it takes all of us, it takes our team. So thank you from that side. But I'm going to continue. We're going to talk about quickly how to refer patients to Retina South Africa. We do have a hospital patient registration form, which you need to sign. And you can then WhatsApp a photo of that to Yonella or to Gail. And I'm sure that you can either take a note of their numbers here, a quick screenshot, or you can email it to pe.office@retinasa.org.za. But we also have a lovely, easy solution for you, and that is the free Vula Medical app. The reason we've introduced the app or joined the Vula community, medical community, is because it is really difficult to copy, email, you need equipment, it's time consuming. The photograph doesn't always come out that well. WhatsApp, it depends if you have where you are, etc. So what is the alternative? As we said, the Vula Medical Referral app. Now, the Vula Medical Referral app, I just want to point out, was created by an ophthalmologist and has proved incredibly successful in our country. It is used across the board. It is a very secure medical chat and referral device. It connects healthcare workers by using this very easy platform. Now, it's very easy to use. All you do is you download the Vula Medical Referral app, either from App Store or from Google Play, and it is a free app. It costs you nothing at all. You then complete your details, including either your HPCSA or Nursing Council number, or you can include your practice number. So it's either your number, your practice number, or if it is a nurse doing this for you, it is the Nursing Council number. And you then almost immediately will receive a confirmation from Vula. They will check your credentials and let you know. Once you've done this, the number has increased and you can then interact with almost 5,000 practices countrywide, with more than 20,000 healthcare workers countrywide. And in this way, healthcare workers have been able to refer, chat, and interchange information for more than 500,000 patients. Now, these numbers are already about 7 months old, so I'm sure those numbers have increased because I know it's increasing exponentially. And then once you're registered to use the app, you simply click New Referral, then you'll find Retina South Africa, complete the patient details, which is just basically their name and diagnosis, and you send it to us. And as we've said, South Africa has the clinical expertise. We know that treatments are imminent. Coping skills can improve the quality of life for your patients, but we need your help.
So we'd like to ask you to help us at no charge to yourself. Please go online to myschool.coza and nominate Retina South Africa as a beneficiary. You can have up to 3 beneficiaries. And when you shop at any of the BP garages, Woolies, any of the stores that are linked in, we will get a small donation, and we can increase that donation. If we have everybody who cares about vision nominating us, it would be wonderful, because in fact, we would raise a lot more money, which helps us to provide better service to your patients. And that's, I think, all I've got to say. And I think it's time to see if we've got any questions. Have Dr. Florence for some questions. Oh, and we've got a helpline, which is at 0860 595959. You can get hold of the PE office or Retina via our website, which is retinasa.org.za. Are there any questions?
Or maybe we were so clear that we've explained everything anybody ever needed to know.
Or it's so early in the morning, nobody's yet in in active mode. Are there any questions on that side, Dr. Florence?
No, nothing from this side. Thank you very much for a very comprehensive talk.
Okay, we'll hand over to you, Gail, to close.
Well, once again, may I say thank you to you, Claudette, and to Karen for sharing your knowledge with us in the Eastern Cape. We never get enough, and we're always learning something new when the two of you connect with us down here. So thank you very much. And may I say thank you to the ophthalmologists, optometrists, nurses that might be listening. Thank you so much for joining us this morning, for partnering Retina South Africa in our efforts. And may I say a special thank you to Dr. Florence for organizing this morning's people to attend the webinar. Dr. Florence, much appreciated, and to each and everyone who's given up their time so early in the morning.